endocrine pathology, Cushing syndrome, and adrenal insufficiency. All right, so to begin off with Cushing syndrome, all that it is, and remember this is Cushing syndrome, and you'll see why I'm saying this right now. Cushing syndrome just means that there's an increase in cortisol, okay? That's all that it means. And it can be caused by different pathologies, okay? The first cause of Cushing syndrome, or an increase in cortisol, that makes the most sense, is right from the source that produces cortisol. So where is cortisol produced? It's produced at the adrenal glands. So this is known as primary adrenal adenoma or hyperplasia, or if there's a carcinoma, right? But if there's any type of hyperplasia at the adrenal glands, something that's constantly increasing production of cortisol at the source, at the adrenal gland, then that can lead to an increase in cortisol in the blood. Now, if we have an increase in cortisol in the blood, that means it's going to cause a negative feedback system and cause a decrease in ACTH. All right, so that's the first cause of Cushing syndrome. You're going to see an increase in cortisol and a decrease in ACTH. And if they say there's a hyperplasia of the adrenal glands, then you know that it's coming right from the adrenal glands. That's the issue. Number two, it could be exogenous glucocorticoid usage. Exogenous glucocorticoid usage is going to see an increase in cortisol, and that cortisol coming from an exogenous site, like medications, is going to have a negative feedback system once again, and you're going to see a decrease in ACTH. Okay, now how do you tell the difference between the first two that I just said? Whether it's a cause of exogenous usage of glucocorticoids or a problem with the actual adrenal glands? Well, you look at the adrenal glands. If the adrenal glands are atrophied, that means that it's exogenous glucocorticoids is causing the increase in cortisol. But if the adrenal glands have hyperplasia, they're thickened, that means that the increase in cortisol is secondary to something that's coming specifically from the adrenal gland. Okay, so does that make sense? Now, those are two causes of Cushing syndrome, and hence an increase in cortisol. And the third thing that leads to an increase in cortisol is Cushing disease. All right, so that may be confusing, but Cushing disease is one of three causes of Cushing syndrome. And all Cushing's disease is ectopic production of ACTH. Okay, so ACTH that's being secreted somewhere else or at the pituitary. Okay, so if we have a pituitary adenoma that's secreting ACTH, or if there's ACTH that's being secreted somewhere else by a neoplasm, by a cancer. All right, and the most common cause of this Cushing disease is small cell lung cancer. All right, so small cell lung cancer can lead to paraneoplastic syndrome, leading to an increase in production of ACTH secretion, which then causes bilateral adrenal hyperplasia. Now, you might be asking, well, how do you tell the difference between this ACTH secreting pituitary adenoma or paraneoplastic syndrome, Cushing's disease, essentially, from a primary adrenal adenoma or hyperplasia? Because both of them have bilateral adrenal hyperplasia at the end of the day. Well, the way you tell the difference is via ACTH levels. If it's a primary problem at the adrenal gland that's leading to the increase in production of cortisol, and you have decreased ACTH levels, then you know that that's what you're dealing with. But if you have increased ACTH levels with bilateral adrenal hyperplasia, then you know that you're dealing with a neoplastic syndrome, paraneoplastic syndrome, or ACTH secreting pituitary adenoma, hence Cushing disease. Okay? So once again, the three causes of Cushing syndrome are: one, exogenous glucocorticoid usage, which you'll see decreased ACTH usage as well as bilateral adrenal atrophy. Number two, it's going to be a primary problem right at the adrenal medulla, or I should say the adrenal cortex. And there's going to be like an adenoma, hyperplasia, or carcinoma at the adrenal gland that's leading to an increased production of cortisol. You're going to see a decrease in ACTH levels, but you're going to see hyperplasia of the adrenal glands. And then the third cause of Cushing syndrome is Cushing disease. And this is an increase in production of ACTH, whether it might be directly from the pituitary or from an ectopic site like cancer that can be causing paraneoplastic syndrome, like small cell lung cancer. And you're going to see bilateral adrenal hyperplasia with increased ACTH levels. So those are the three main causes, three common causes that they're going to test you on for Cushing syndrome. Once again, Cushing syndrome just means that there's increased cortisol levels, all right? Exogenous glucocorticoid usage and primary adrenal hyperplasia both have decreased ACTH. The only one that has increased ACTH levels is Cushing disease, and that's just an increase in ACTH production by either the pituitary adenoma, or by a paraneoplastic, so a neoplasm like small cell lung cancer. All right, I know I hammered that in like so many times. I said that so many times, but it's very, very high yield. You have to understand it in order to understand Cushing syndrome and the questions that they're going to ask you. All right, next is the findings. How can we tell from a vignette that the patient has Cushing syndromes? Well, Number one thing is moon facies, round facies. Increase in cortisol causes this round appearance of the face, and you can see a photo of it. It also causes a buffalo hump in the back of the neck. You're going to see also hypertension due to the fact that increased cortisol stimulates mineralocorticoid receptors. You can see hyperpigmentation due to the fact that we have increased MSH from increased POMC. You can get these striations, skin changes, and they're these striations on the stomach. They'll say like hyperpigmented stripes of red on the abdomen. They're not going to tell you striations. Those are the key ones, so keep those in mind. The last one also is androgen synthesis. There's excess androgen, and that's due to the fact that ACTH also stimulates adrenal androgens. Okay, so keep that in the back of your mind. But those are your findings. Now, how can we diagnose it? They love to ask about Cushing syndrome diagnosis. Very, very important. So what do? Well, we already said there's 3 etiologies. There's 3 causes of Cushing syndrome. The first one is a exogenous glucocorticoid usage. And once again, that's going to be decreased ACTH with bilateral adrenal atrophy. If you see adrenal atrophy, then boom, your answer is going to be exogenous glucocorticoids. Okay? Now, for the other 2, we actually have to use some diagnostic methods and screening tests in order to differentiate them. Okay? And the main diagnostic method that we use is high-dose dexamethasone. And all that is, first off, dexamethasone just is a glucocorticoid. Okay? It is very similar to cortisol. It does the same actions as cortisol. It's a glucocorticoid. Okay? That's just what dexamethasone is. So that's the first thing that you have to understand. Okay? So when I give dexamethasone and it acts accordingly in the body as exactly like cortisol, that means it's going to have a negative feedback loop. It's going to participate in the negative feedback loop on the pituitary and cause a decrease in ACTH because it acts like cortisol. And so since it acts like cortisol, it's going to bind to the receptors in the pituitary and say, hey, we have high levels of cortisol. You can decrease the production of ACTH. Okay, so that is very key to understanding the high-dose dexamethasone screening test. Because when we have a pituitary adenoma, right, that means that at the pituitary, we're going to have increased ACTH being produced because of an adenoma. And that is going to lead to cortisol being produced in excess at the adrenal gland. But when I give them high-dose dexamethasone, they're going to see a decrease in cortisol. And the reason behind that is because we're giving them such high levels of cortisol that the pituitary adenoma is going to be shut off by the negative feedback system because the high-dose dexamethasone is acting as a very, very potent cortisol. So you're going to see a drop in overall levels of cortisol when you give a patient with a pituitary adenoma high-dose dexamethasone. Very important. Okay, so the etiology is pituitary adenoma. So that's you're going to see an increase in ACTH and increase in cortisol. But right when I give them high-dose dexamethasone, it's going to work. It's going to be working a part of the negative feedback loop, and it's going to cause a decrease in cortisol, a drop in cortisol. Very important. Because for my other 2, with ectopic ACTH secretion, I have increase in ACTH and increase in cortisol. So I can't tell the difference between a pituitary adenoma and ectopic ACTH secretion, right? Because you both have increase in ACTH and increase in cortisol, right? But when I give patients with ectopic ACTH secretion, like patients that have small cell lung cancer, if I give them high-dose dexamethasone, the cortisol levels remain the same. And the question is, why does that make sense? Well, the reason that makes sense is because if I give patients that have small cell lung cancer with an ectopic ACTH secretion, this high-dose dexamethasone, the high-dose dexamethasone is going to go back to the pituitary and play the part in the negative feedback loop, but it doesn't matter because small cell lung cancer is not a part of the normal anatomical negative feedback loop. It's producing its own ACTH, and it doesn't have any cortisol receptors in order to play the game of the negative feedback loop. So it can't sense high levels of cortisol. So it doesn't care because it's cancer. Who cares if there's high levels of cortisol? I'm not playing a part of the negative feedback loop. I don't have receptors for cortisol. I don't have receptors for dexamethasone. So I'm not going to decrease my ACTH production. I'm a cancer. All right? I'm losing my mind. I'm producing as much as I want. I don't care. And so that's why ectopic ACTH secretion, you're going to see increased levels of ACTH and cortisol, just like pituitary adenoma. But when I give the patient high-dose dexamethasone, I do not see any drop in cortisol. Cortisol remains elevated. Okay? But in pituitary adenoma, my cortisol actually decreases because it has cortisol receptors. It has receptors that dexamethasone can act on in order to play the part in the negative feedback loop. Okay? Lastly, adrenal adenoma or adrenal carcinoma. Okay? This is like primary adrenal hyperplasia, primary adrenal adenoma, or carcinoma. So you're going to have, once again, a decrease in ACTH because the problem is at the adrenal gland, and an overall increase in cortisol, right? Because this is Cushing syndrome. You're obviously going to have an increase in cortisol in all of these. Now, the question is, if I give a patient high-dose dexamethasone with an adrenal adenoma, primary adrenal adenoma, or carcinoma, is anything going to change? No. Well, it's going to use the negative feedback mechanism, right? High-dose dexamethasone is going to go back and use the feedback mechanism. But who cares? There's already decreased levels of ACTH because our body's already sensing increased levels of cortisol because there's a problem actually at the adrenal gland. It's a primary problem. It's a problem at the adrenal gland, okay? So it doesn't matter if I give them high-dose dexamethasone. There's already increased levels of cortisol that's working on the negative feedback loop to cause decreased levels of ACTH. So it doesn't even matter, okay? So I'm going to run through this quickly and clearly so you understand this one more time. So, Cushing's disease is ACTH secreting pituitary adenoma, okay? And that pituitary adenoma has blood levels of increased ACTH and increase in cortisol. If I give that patient high-dose dexamethasone, that dexamethasone can work with the negative feedback loop and cause an overall drop in cortisol. If it drops the cortisol, then I know it's Cushing's disease, aka pituitary adenoma, okay? Number two, if I see increase in ACTH and an increase in cortisol, it could be ectopic ACTH secretion. That is not known as Cushing disease. It's separate, all right? It is caused by usually a neoplasm, a cancer, specifically small cell lung cancer. Now, the way that I could tell that it's not Cushing's disease and it's actually a paraneoplastic ACTH secretion or an ectopic ACTH secretion is that when I give them high-dose dexamethasone, the cortisol levels stay the same because there's no negative feedback loop or cortisol receptors that dexamethasone can act on these cancers, on these tumors that are causing this ACTH secretion, okay? Because it's not located at the pituitary, it's somewhere else in the body. Lastly, if I see an overall decrease in ACTH, you can rule everything else out and pick between exogenous glucocorticoid usage and primary adrenal adenoma, hyperplasia, or carcinoma. And the way that we differentiate between those two is that exogenous glucocorticoid usage will have bilateral adrenal atrophy, whereas primary adrenal adenoma will have a decrease in ACTH with a bilateral adrenal hyperplasia. Okay? I hope I made that clear. If there's any questions, please reach out. This is a very hard topic for people to understand, but keep an eye out for what the diagnostic screening tests are, because that's the question that they love to ask, that high-dose dexamethasone. Next, I'm going to be moving on to adrenal insufficiency. Adrenal insufficiency is also a very difficult concept to understand, but all that it is, first and foremost, is inability of adrenal glands to generate enough glucocorticoids. So while Cushing syndrome is too much cortisol, this is essentially too little cortisol or too little glucocorticoids being produced by the adrenal glands. So they're opposites. And the primary adrenal insufficiency is going to be a problem specifically at the adrenal glands, okay? So that's a very common thing that you have to understand. When they say primary, it's directly at the site that's secreting it. When they say secondary, that means it's a step above, okay? And tertiary is even further, okay? So primary is at the site, which means that there's a problem specifically at the gland, the adrenal gland. So you have an overall decrease in gland function that leads to a decrease in cortisol and aldosterone, right? Our glucocorticoids and mineralocorticoids, all right? Very hard to call out. But the number one thing I look for is that if a patient has GI issues and hyperpigmentation, then that's the first thing I look for primary adrenal insufficiency. This is also known as Addison's disease. Okay? It's so hard to pull out in a vignette. But when you look at a vignette, and I'm telling you right now, this was the easiest and best way that I looked at it. If I saw GI issues and hyperpigmentation, then I started thinking primarily in my head, primary adrenal insufficiency. That was the first thing in my head for my diagnostic factors, okay? You have to look for GI issues and hyperpigmentation. That GI issues could be, they have abdominal pain or they've been throwing up, okay? Those are the GI issues you're looking for. Constipation could be, it could be so many different things, all right? Number two thing I would look for was an autoimmune disease, meaning maybe it could be type 1 diabetes, right? Or any other autoimmune disease with a decrease in cortisol and aldosterone. That's another hint for primary adrenal insufficiency. That's more straightforward, okay? It usually coexists with those autoimmune diseases like type 1 diabetes or TB. It could coexist with TB, all right? So those are the two things you have to keep in mind. Patient with GI issues and hyperpigmentation, start thinking about primary adrenal insufficiency, or if they give you an autoimmune disease, patient with autoimmune diseases, or TB, or type 1 diabetes, right? Type 1 is autoimmune, with decreased cortisol and aldosterone, then primary adrenal insufficiency. All right. Now, the question you might be asking, why does the patient have hyperpigmentation? Well, once again, the patient has hyperpigmentation because increased melanin synthesis due to the fact that we have increased MSH, a byproduct of POMC cleavage, right? Well, why do we have increase in POMC cleavage? Because we have increase in ACTH that's trying to get cortisol and aldosterone to be increased, but we can't because there's a problem at the adrenal gland that cannot produce cortisol or aldosterone, right? And so that's why we see the hyperpigmentation, right? And that's Addison's disease. Very important, all right? And since we have a decrease in aldosterone, you will see a decrease in sodium as well as bicarb. And then that means that you'll have an increase in potassium and chloride. All right. This can lead to bilateral adrenal hemorrhage, which we'll talk about later on soon enough. But we're going to have to first talk about tertiary adrenal insufficiency. Secondary adrenal insufficiency, it doesn't matter. But tertiary adrenal insufficiency, what they care about specifically is that it's secondary to stopping treatment, abrupt cessation of glucocorticoid therapy. Now, the question is, why does that make sense? Well, when I have chronic glucocorticoid therapy, what did we talk about in Cushing syndrome? What we talked about is that you have bilateral adrenal atrophy, right? Because if I'm supplying my own body with exogenous cortisol, that means that my adrenal glands don't have to do their job anymore. Hey, we don't have to produce any more cortisol because there's already cortisol floating around. So the organ that actually should be producing that cortisol is just going to atrophy because it's like, hey, I'm not needed anymore. But then what happens when I just completely abruptly stop my exogenous glucocorticoid usage? Well, I don't give my body time to kind of build back my adrenal glands in order to produce normal amounts of cortisol. So when I stop abruptly all that exogenous glucocorticoids, then there's no more glucocorticoids to be had, right? Because I already have atrophied glands and I can't build back up. I can't secrete anything. So you're going to go into this adrenal crisis, right? So you're going to have an overall decrease in cortisol production and aldosterone production and an overall decrease in glucocorticoids in the body. And this can also lead to bilateral adrenal hemorrhage, okay? This is known as acute adrenal insufficiency, all right? And this is Addisonian crisis. There's so many names for it, okay? And so this will lead to a problem because when you have acute adrenal insufficiency, also known as Addisonian crisis, that means that you need an increase in glucocorticoid requirement, but you can't meet those requirements, okay? And so that could be secondary to our primary adrenal insufficiency, Addison's disease, where there's a problem with the gland, or it could be due to tertiary adrenal insufficiency when I abruptly stop treatment, okay? So at times that I have decreased glucocorticoids, but I need increased glucocorticoid requirement, I can go into this acute adrenal insufficiency state, and that can lead to a very scary pathology known as Waterhouse-Friderichsen syndrome. And this is when I have bilateral adrenal hemorrhage. I start to hemorrhage in my adrenal glands, okay? Because they're trying to produce so much stuff, but they just start to hemorrhage because I don't have the capacity to produce it, all right? Very, very important, okay? You have to understand that. Very scary. Now, and like something that they love to talk about for Waterhouse-Friderichsen syndrome is sepsis. So patients that are in like sepsis, they have an increased risk for this because they have an increased needing, the requirement for glucocorticoids. They need glucocorticoids because their body is in a stressful state. And so sepsis, specifically meningococcemia, we'll talk about that later on, and micro, that can lead to Waterhouse-Friderichsen syndrome, which all that is bilateral adrenal hemorrhage. Okay, and you have to treat that quickly by giving them glucocorticoids. All right, so overall, that's it. That's Cushing syndrome and adrenal insufficiency. Quick overview, all right, because this has been a long, long video. What do we care about? Most important things. Cushing syndrome just means increased cortisol. There's primarily three etiologies that we care about. Exogenous glucocorticoids can lead to increased cortisol, but that's going to have decreased ACTH levels and bilateral adrenal atrophy. Number two is primary adrenal adenoma, hyperplasia, or carcinoma. Since it's primary, that means there's a problem with the gland. And so that's secreting so much cortisol, all right, and it's causing a negative feedback loop on the pituitary gland, leading to an overall decrease in ACTH. But you're going to actually see hyperplasia of the glands, of the adrenal glands, not atrophy. Number three, Cushing's disease. Cushing's disease means that there's a specific ACTH secreting pituitary adenoma. That's all that Cushing's disease means, okay? I might have messed up in the earlier when I was talking, but Cushing's disease only means ACTH secreting pituitary adenoma. So from the pituitary, there's an adenoma there, it's secreting ACTH. Okay, what do we care about that? There's going to be increased levels of ACTH, increased levels of cortisol. But when I give them high-dose dexamethasone, you're going to see a drop in the cortisol levels. Lastly, a cause could be perineoplastic ACTH secretion, meaning it's coming from a cancer. It's coming from an ectopic site, secondary usually to small cell lung cancer. You're going to see also increased ACTH and increase in cortisol, but the way that you tell the difference between ectopic ACTH secretion and Cushing's disease is that when you give the patient with ectopic ACTH secretion high-dose dexamethasone, nothing changes. Cortisol remains elevated. And that's due to the fact that there's no negative feedback loop or receptors on these tumor cells. Okay? Hopefully that makes sense. Moving on to adrenal insufficiency. Most importantly, primary adrenal insufficiency. Well, first off, adrenal insufficiency just means that you can't produce glucocorticoids. Primary adrenal insufficiency, there's a problem at the gland. You can't produce our cortisol or aldosterone. So you have a decrease in cortisol levels, decreased aldosterone levels. How can I look at it from a vignette standpoint? If you see a patient with GI issues, any type of GI issues, even if they're feeling nauseous, that's a GI issue, okay? GI issues with hyperpigmentation, start thinking about primary adrenal insufficiency. Also, autoimmune diseases with decreased cortisol and aldosterone levels, start thinking about primary adrenal insufficiency, like type 1 diabetes or TB. The patient's going to present maybe potentially with decreased sodium and HCO3 because of their decrease in aldosterone. But they can also have increased potassium and chloride levels because of the loss of the sodium and bicarb levels. Okay? This can lead to bilateral adrenal hemorrhage, all right? And so can tertiary adrenal insufficiency. Tertiary adrenal insufficiency is just due to abrupt cessation, abrupt stopping of glucocorticoid usage, chronic glucocorticoid usage. And that can lead to hemorrhaging within our adrenal glands, known as Waterhouse-Friderichsen syndrome. We have to treat this quickly with glucocorticoids. If you don't treat it quickly with glucocorticoids, you lead to this bilateral adrenal hemorrhage in the setting mainly in sepsis, and it's end game. All right, that's it. Cushing syndrome, primary adrenal insufficiency, tertiary adrenal insufficiency, as well as Waterhouse-Friderichsen syndrome. You have to know these. Very high yield, very tested on. If you have any questions, please reach out. This is going to be the longest chapter in all of our endocrine system.